providing health care and in education, in the field of education also. So, in this situation, we find it very challenging. We can achieve it. We have a hope to achieve to bringing in the latest treatments in the coming days to meet out the requirement of the society. And with that, we are celebrating this 25th. Then we have to go a long way in servicing the people with the best care. I once again thank all of you here. Especially I am thank for his kind help, Dr. D. Mani, Dean of the Salem Mohan Kumar Mangalam Medical College, and also Madam Valarmadi, Joint Director of Health and Services Salem, to be here to inaugurate this, and also being the chief guest of the day, and Dr. B.R. Gemini, Deputy Director of Health Services, Athur. I am very glad to welcome them. Thank you, sir, for your presence here. And I also welcome Dr. M. Ganesh, MD, MRCP, Gastro, London, from Coimbatore, Chairman of Chief Gastroenterologist, SG Gastro Care, Coimbatore, and Dr. Palani Rajan, MD, Dipend B, Nephrologist, from Shasta Kidney and Multi-Speciality Hospital from Madurai, and Dr. A.S. Nadarajan, MD, TB and chest diseases, pulmonologist, Vijaya Group of Hospital, Chennai. I welcome every one of you here. Thanking you, sir.
Thank you, sir. I'm profusely elated to take the opportunity to introduce our chief guest, Dr. R. Mani, Dean, Government Mohan Kumaramangalam Medical College, Salem. Dr. R. Mani did his undergraduation and post-graduation from Stanley Medical College, Chennai, and worked as a professor in the Department of Pharmacology from 2012 to 2020, and sir has been dean since. He had published papers and even co-authored a book on adverse effects of drugs. He had also received the certificate of appreciation from the government of Tamil Nadu for providing his generous services during the pandemic. With this small introduction, kindly share a few words with us, sir.
Respected Mr. S. Devarajan, sir, Managing Trustee, SPMM Hospital. Respected Guest of Honor, Madam Valarmati, JD Family Welfare. Dr. B.R. Gemini, Deputy Director of Health Services, Athur. Respected Dr. M. Ganesh, who has come here for a scientific session. Chairman and Chief Gastroenterologist, SG Gastro Center, Coimbatore. Respected Dr. S. Palnirajan, MD, DNB, a nephrologist from Shasta Kidney and Multi-Speciality Hospital, Chennai, Madurai, who's come over here to talk on chronic kidney disease. And respected Dr. A.S. Nadarajan, MD, Chest Medicine, pulmonologist from Vijaya Group of Hospitals, Chennai. And other respected members of the SPMM hospital. It's a privilege, and I'm happy to be here on a proudful day where the SPMM hospital is celebrating their silver jubilee. It's a great pride on the part of the managing trustees, the words that they were speaking, the dreams of their forefathers, which has been taken forth. That is the happy moment that gives them. A growth of a hospital depends, as far as I am concerned, on the sustainability. And this sustainability is, in every spectrum, is wide evidenced. Because last month I was with them on a function where they were distributing artificial limbs to people at their hospital itself. And now that they have come up with a new diagnostic device, and this a wide spectrum of development can only be done when there is a loyal workers with them. See, the loyalty that has been shown by the SPMM hospital faculties, medicine and paramedical people, and the sustained effort, the care that they have given to meet out the demands of the public is appreciable. As sir was saying, what amount of hospital that can come up by the government of Tamil Nadu or government of India will not be sufficient because of the ever-growing population and the newer evolution of, or the older diseases coming once again back into the presence. So all these ailments has to be addressed by a combined effort of both the private, public sector and the governmental sector. In that way, I think to the amount of attention that this SPMM hospital that is given to that region of Ammapet is highly appreciable, because I know this for a long time. Since I started my medical profession, I've been hearing about SPMM hospital, and I was telling them also that is very close to my heart since I started my school in their region. So I can always understand, because of this expansion of the city and the proximity of a governmental hospital or medical college, specialty hospital, the proximity is not so. So that sect of people should be taken care of by hospitals like SPMM. In that manner, I think they have done a very great job, and I invoke the Almighty to bless them further and in their progress. That should happen for the benefit of the people. Thank you, sir. Thank you so much.
Thank you, sir. I request Mr. S. Devarajan to honor Dr. R. Mani, Dean, Mohan Kumaramangalam College, Salem.
Thank you, sir. I'm profusely overjoyed to introduce our guest of honor, Dr. Valamadi, Joint Director of Health Services, Salem. Dr. Valamadi is an inspiration for many, as the accomplishments she has made are not an easy task. She has completed her graduation at Tanjavur Medical College and did a dedicated service in PHC for 21 years and more than 10 years of service in government hospitals. She also worked as the Deputy Director of Family Welfare, Salem. Presently, she is working as Joint Director of Health in Salem. I request Dr. M. Valamadi to share her thoughts with us today.
Happy morning to one and all. I feel immense pleasure to be here, the facilitator for 25th year of the Noble Medical Services given by the SPMM Hospital to the society. I take opportunity to extend my appreciation to the SPMM Hospital for inauguration of the 1.5 latest MRI scan equipment. The science has developed and explored all the possible way to diagnose and treatment the facility today. Government has also taken a good initiative both in primary, secondary and tertiary level healthcare, aiming to achieve the health indicators in the society, where we are reaching the universal health coverage developed by the whole health organization. Acquiring the knowledge, the medical system is a part of the career. I am happy to see the young medicos who gathered here will be gaining the knowledge in spite of the knowledge in the different specialty, so that they can learn and put that in the practice in serving the society. On April 7th, we are going to celebrate the World Health Day in the theme of Health for All. We shall take the responsibility to reach everyone the health coverage, both primary, secondary and tertiary care. I wholeheartedly congratulate the SPM Hospital to have a centuries to do more services in the society. Thank you to one and all.
Thank you, ma'am. I request Mr. Selvaraj to honor Dr. M. Valamati, Joint Director of Health, Salem.
Thank you, sir. Thank you, ma'am. It's our immense pleasure to take the opportunity to introduce our guest of honor, Dr. B.R. Gemini, MBBS, Deputy Director of Health Services, Athor. Dr. B.R. Gemini graduated from Stanley Medical College in 1983 and completed his DPH from Madras Medical College. Being a passionate person, he was associated in various positions, from being assistant professor in Government Mohan Kumaramangalam Medical College to being a deputy director of health services in several districts. He had also received appreciation for best service in public health from Honorable CM and Honorable Health Minister for getting NQAS. Kindly share your valuable thoughts with us, sir.
அனைவருக்கும் காலை வணக்கம். இந்த மேடையிலே விட்டிருக்கும் திரு தேவராஜ் ஐயா அவர்களுக்கும், திரு தினகரன் ஐயா அவர்களுக்கும், திரு செல்வராஜ் ஐயா அவர்களுக்கும், இந்த நிகழ்ச்சியினுடைய தலைவர் டாக்டர் மணி அவர்களுக்கும், டாக்டர் வளர்மதி அவர்களுக்கும், மற்றும் இந்த சயின்டிஃபிக் செக்ஷன் கருத்துக்களை வழங்கவிருக்கிற மருத்துவர் கணேஷ், மருத்துவர் பழனிராஜன், மருத்துவர் ஏஎஸ் நடராஜன், மருத்துவர் பெரியசாமி உள்ளிட்ட இங்கு வந்திருக்கும் அனைவருக்கும் இந்த வாய்ப்புக்கு ஒரு நன்றியினை தெரிவித்துக் கொண்டு சிலவற்றை உங்களோடு இந்த 25வது ஆண்டு எஸ்பிஎம்எம் நினைவு மருத்துவமனை I started my career in Harur as a general practitioner in 90. So on the time we used to think ஒரு நல்ல ஹாஸ்பிட்டல் சேலத்தில் இருந்தால் பரவாயில்ல அப்படின்னு சொல்லிட்டு ஒரு சில ஹாஸ்பிட்டல் இருக்கும். ஸோ அந்த ஹாஸ்பிட்டல் கூட பேஷண்ட்டு ரெஃபர் பண்ணி நாங்கள் ஆத்தூர், சேலம், அந்த மாதிரி அரூர் அந்த ஏரியாவில் வரும்போது குறிப்பாக வந்து அக்யூட் எமர்ஜென்சிஸ் தான் வரும். ஸோ இங்கே ஜிஹெச்சில் பார்த்தீங்கன்னா நிறைய க்ரௌட் இருக்கும், இருக்காது. ப்ளஸ் கன்சல்டன்ட் இருக்க மாட்டாங்க. ஸோ அப்போ தான் வந்துட்டு வி காட் த நியூஸ். ஸோ இங்கே ஒரு ஹாஸ்பிட்டல் கட்ட போகிறாங்க அப்படின்னு சொல்லிட்டு. ஸோ பார்த்தீங்கன்னா ஹாஸ்பிட்டல்லாம் யூஸ்வலாக டாக்டர்ஸ் ஆரம்பிப்பாங்க. ஸோ அதர் தேன் டாக்டர்ஸ் வந்து பண்ணுறதுக்கு 2 விஷயம். ஒன்று பணம் இருக்கணும், இன்னொன்று மனம் இருக்கணும். ஸோ பணம் வச்சுருக்கிறாங்க, ஏற்கனவே ஒரு பிஸ்னஸில் இருக்காங்க. அவங்க they could have started their another unit of yarn industry, yarn business. அதில் உங்களுக்கு நமக்கு தெரியும் எவ்வளோ பணம் வரும்னு சொல்லிட்டு. பட் ஹாஸ்பிட்டல்னு வரும்போது ஒன்று எக்ஸ்பீரியன்ஸு ப்ளஸ் கெட்டிங் கன்சல்டன்ட் இஸ் வெரி டிஃபிகல்ட். 25 இயர்ஸ்க்கு முன்னாடி அதை தாண்டி ஒரு ஹாஸ்பிட்டல் ஆரம்பித்து இன்னைக்கு சேலத்து நடு ஒரு அடையாளமாக பண்ணியிருக்காங்கன்றதுக்காக கண்டிப்பாக வந்து அனைவரும் வந்து ஒரு நல்ல ஒரு சிறந்த கைத்தட்டலோட நம்ம பண்ணணும். அதே மாதிரி 3 விஷயங்கள் வந்து ரொம்ப இம்பார்ட்டண்ட். அந்த ஏங்கிற எழுத்து எவ்வளோ முக்கியம். அதில் வந்து அக்சசபிலிட்டி, அஃபோர்டபிலிட்டி அண்ட் அக்செப்டபிலிட்டி. தட் இஸ் 3 வேர்ட்ஸ் ஆர் வெரி இம்பார்ட்டன்ட். அதை பார்த்தீங்கன்னா அக்சஸ். ஸோ அங்கே இருக்கிற வில்லேஜில் இருக்கிறவங்களுக்கு இப்போ தான் வந்து நமக்கு பைபாஸ் எல்லாம் வந்திருக்குது. இப்போ தெர் வாஸ் நோ பைபாஸ். அந்த கார்னர் வந்த உடனே இம்மீடியட்டாக ஒரு கார்டியாக் எமர்ஜென்சி ஆர் ஒரு பாய்சன் மேனேஜ்மெண்ட். ஏன்னா நம்ம ஊர்லலாம் ரொம்ப பாய்சன் கேசஸ் வந்து நிறைய வரும். அடுத்து ஆர்டிஏ. ஸோ இதுக்கு வந்து அவங்களுக்கு அடுத்தது அஃபோர்டபிலிட்டி. ப்ரைவேட் ஹாஸ்பிட்டல் போனாவே நம்மளால் வந்து செலவு பண்ண முடியாது, அந்த மாதிரியான ஒரு எண்ணங்கள் இருக்கும். அதை மாற்றி அங்கே போனால் கண்டிப்பாக வந்து நம்மளோட அஃபோர்டபுள், ஃபீஸ் ஜாஸ்தி இருக்காது, கண்டிப்பாக பழச்சி வந்துடலான்றது. அதுக்கப்புறம் பார்த்தீங்கன்னா அங்கே பீப்புளோட அக்செப்டன்ஸ் நிறையவே இருந்தது. அது வந்து அதெல்லாம் முக்கியமான ரீசன்ஸ் ஃபார் தி டெவலப்மெண்ட் ஆஃப் த ஹாஸ்பிட்டல். அப்படி கன்சல்டன்ட் எடுத்துக்கிட்டிங்கன்னா சேலத்துக்கு வந்து கார்டியாலஜிஸ்ட் ஆகட்டும், நெஃப்ராலஜிஸ்ட் ஆகட்டும், யூராலஜிஸ்ட் ஆகட்டும், தி பெஸ்ட் கன்சல்டன்ட் வந்து இன்னைக்கு வரலாம் அவங்க அந்த ஹாஸ்பிட்டலில் வந்து இருக்காங்க. ஸோ தட் இஸ் தி எப்போவுமே இந்த குவாலிட்டி காம்ப்ரமைஸ் பண்ணிக்காமல் இன்னைக்கு வரலும் நல்லா பண்ணிட்டு இருக்கிறாங்க. அண்ட் பின் அசோசியேட்டட் வித் தம் ஃப்ரம் டே 1. ஒரு கேஸ் ரெஃபர் பண்ணுற ஒரு ஜெனரல் ப்ராக்டிஷனராக. அதுக்கப்புறம் வென் மை ஃபேமிலி மெம்பர்ஸ் ஹேட் ப்ராப்ளம்ஸ், அங்கே வந்து ஐ ஸ்டேட் தேர் ஆஸ் அ அட்டெண்டர் ஆஃப் தி பேஷண்ட்ஸ். ஸோ அப்போ வந்து அங்கே என்ன கேர் கொடுக்குறாங்கன்றது ஐ ஹவ் சீன், இன்க்ளூடிங் ஃபுட், இன்க்ளூடிங் மெயின்டெனன்ஸ் ஆஃப் த ஹாஸ்பிட்டல். ஸோ எல்லாமே பார்த்தீங்கன்னா தி பெஸ்ட் அந்த மாதிரி இருக்கும். ஸோ அது வந்துட்டு அதே மாதிரி இதுவரையிலும் பார்த்தீங்கன்னா இப்போ நம்மளுடைய அந்த சர்வீசஸில் பார்த்தீங்கன்னா மார்டாலிட்டி இஸ் வெரி மெயின் கீ இம்பார்ட்டன்ட் ரோல் வந்து பார்த்தீங்கன்னா ஒரு பேஷண்ட் கேருக்காகட்டும் அல்லது நம்முடைய அந்த டெவலப்மெண்ட்டுக்காகட்டும். ஸோ அதில் பார்த்தீங்கன்னா வெரி மினிமம், இன்ஃபேக்ட் ஐ கேன் சே 0 சோஃபார் வந்து பார்த்தீங்கன்னா அங்கே 100% வந்து நமக்கு வந்து ப்ரோக்னோசிஸ் நல்லாயிருக்கும், டெஃபினட்டாக வெளியே வந்துடலாங்கன்ட்டு. ஸோ அந்த மாதிரி ஒரு நல்லா பண்ணியிருக்கிறாங்க. I used to discuss with the members of the hospital management as well as the consultants. ஸோ ஏன் இவங்க ஒரு மெடிக்கல் காலேஜ் ஆரம்பிக்கக்கூடாது அப்படின்னு சொல்லிட்டு ஐ டோன்ட் நோ வை தே வுட் நாட் தாட் ஆஃப் தட். ஸோ இந்த இனிமையான நாளில் இந்த துறைக்கு வந்து சர்வீஸ் மைண்டோட ஒரு மருத்துவ கல்லூரி, மருத்துவ அந்த ஸ்கூல் ஆஃப் அந்த பேராமெடிக்கல் அண்ட் மெடிக்கல் எஜுகேஷன், ஸோ அதை வந்து பண்ணுறதுக்கான ஒரு வேண்டுகோளாகவும் இந்த ஒரு நிகழ்ச்சிக்கு எனக்கு இந்த மாதிரி ஒரு வாய்ப்பு கொடுத்ததுக்கு அனைவருக்கும் வந்து மீண்டும் ஒரு முறை எனது மனமார்ந்த நன்றியினை தெரிவித்துக் கொண்டு இந்த மருத்துவமனை மேலும் சிறப்பாக வரவும், யூஸ்வலாக நமக்கு வந்து ஆலமரம்னு சொல்லுவாங்க, அது இது வரும், அதுக்கு பிரான்ச்சஸ் இல்லைனாலும் அந்த வேர்கள் இருக்கும். அந்த மாதிரி சின்ன சின்ன ஊர்கள்லையும் they can start their clinics, they can அந்த 24 hours clinic அந்த மாதிரி டே கேர் பார்த்துட்டு so that they can extend their service to the nearest சேலம் டிஸ்ட்ரிக்டில் இருக்கிறதுக்கும் பண்ணணும்னு சொல்லி ஒரு என்னுடைய ஆசையை தெரிவித்துக் கொண்டு வாய்ப்புக்கு நன்றி கூற அமர்கிறேன். நன்றி.
Thank you, sir. I request Mr. Dinakaran to honor Dr. B.R. Gemini, Deputy Director of Health Services, Athur.
Thank you, sir. Now it's time to come in to two of our senior most doctors, Dr. Jonathan Muttunayagam, Consultant Interventional Cardiologist, SPMM, and Dr. P. Mariappan, Consultant Interventional Cardiologist, SPMM, recognizing their extraordinary skill and notable services for a long time here in SPMM. Now I call upon Mr. S. Devarajan to share a few words about the eminent persons.
Dr. Jonathan, MD, DM, cardiologist, interventional cardiologist. He was a cardiologist right from the beginning, very beginning of our cardiac department in our hospital. He is very sincere, very dedicated. We can assure him his presence, the time, the consulting time, as this is the time for consultation means there is no question, he will be available. He is very friendly to the patients and especially every patients, especially the elder people, very fond of him. Once he entered into the hospital, he will not leave the hospital without completing all the patients, seeing all the patients and procedures. That is his attitude, his involvement, his dedication. On this occasion, I take the privilege of honoring him in this occasion. Thanking you.
Thank you, sir. Now it's time for the tea break. I would like to request all our guests to move toward the dining area outside. We'll resume here within 10 minutes. Thank you.
I request you all to assemble here by 11:30 for the scientific session.
நேரம் ஆகணும், குடிச்சா தான் நமக்கு இதாகும். குடிக்கிறது அவங்க மிஸ் ஆகாது. சரி நீங்கள் தான் குடிச்சிட்டு போக பார்த்து
எடுத்துட்டீங்களா?
இல்லை இல்லை, ஏதோ உனக்கு கிடைக்கும், அதனால அப்படியே எங்கள் டாக்டர் கூட
நிறைய ஃபோட்டோ எடுத்து நல்ல பேர் வாங்கிக்கலாம்.
இல்லை போய் போய் என்ன போய் பிஸ்கெட்டை போய் தரானே, ஏதோ ஒரு ஸ்நாக்ஸ்
அவரு புண்ணாக்கு பிஸ்கெட்டு. ஆமாம், மாடுதிக்கு உண்மையிலே மூணு சொல்லலாம். தவிர புண்ணாக்கு தான்
தெரியுது, ஆனால் இருந்தாலும் அதில் தான் சத்து அதிகம். அவங்க அண்ணா
மைதாவை கலந்துடுறாங்களா?
himself, he has partaken in various research works, poster presentation, and has published articles and case reports pertaining to his field of specialization. He was also the first person in the world to remove small intestinal tumor fully by endoscopy without surgery, and has performed more than 1 lakh endoscopic procedures. It is our privilege to call a man of such honor to come up to the dais. It is our privilege to call a man of such honor to come up to the dais and speak on the topic Pearls of Wisdom for Medical Students.
Good afternoon, everybody. It's a great pleasure to be in Salem, and I thank the opportunity given to me for talking about pearls of wisdom, about sharing our experience and knowledge to the medical students. And I thank the organizers, SPMM Hospital, group of managements and arrangements made by them to bring me here to talk about this topic with the medical students. It's always a wonderful pleasure to be with you all, and I belong to Salem also, and my native is Salem, so it always have a connectivity, and my umbilical cord is always with Salem, because we have all the relatives and friends and family friends here living in Salem. And in fact, I can say I belong to Salem rather than being in Coimbatore and practicing in Coimbatore in my hospital, but my soul and heart is in Salem always. And it's a great work, and I congratulate the SPMM group of hospitals for putting up a wonderful show in running this 25 years with great service. And my dear Rotary friend, Mr. Kannan, has accompanied me to this meeting, and he has been much of praise about the SPMM hospital. He is very close to them, and I know that they are doing a very good service, and hopefully we would like to see more of these sort of CME meetings also to share the knowledges for the medical students and medical fraternity organized by an academic institution. So once we are growing like an institution, then we will be requiring more of educational services to them, and that caters the doctors as well, like how we have a relationship with the patients. It's important that we do more educative programs to doctors so that we can share the knowledge and improvise. So then I'll straight away go to the topic, and I hope we have a mixed type of audience here. How many of you are here medical students? Just to know that what I can talk and what you will be able to understand and get the right messages across. Can you put up your hands? Any medical college students? So all belong to Vinayaka or Salem Medical College? Annapurna. Oh, fine. Good. So I think even despite being on a Sunday, I think the only day available for a doctor is Sunday. And that too, even becoming a doctor, these people are here doing their service and job in a Sunday. So I appreciate that's the commitment and the way that the medical society has to move from the medical college. Because once you are committed, you will be committed forever in your life. That's very, very important as being a doctor. And in fact, when I was medical student, I think we don't have much conferences. We keep on looking at the papers or somewhere with the students, postgraduates, keep on asking them, is there any meeting which we can go and attend and learn something? So that is the rarity because we don't have much of meetings. But now we have wonderful meetings and too many meetings are there, but less number of doctors participating because of more busier world. But again, we should keep on attending our choices of meeting and keep updating ourselves. That is very, very important and vital because many points we pick up in the clinical meetings rather than being in the college because we do know the book knowledge and other aspects taught in the medical school. But it is important in a way when you see the meetings and attend the meetings and you will be learning more new points from various different consultants who have different experiences. So with this I'll start my talk and I've structured my talk such that so I was a consultant before going to the talk. A small introduction was given and I was in United Kingdom in Manchester, trained in Manchester. Manchester Royal Infirmary and Salford Royal University, West Manchester General Hospital and University Hospital. Completing my training as a gastroenterologist, I worked as a consultant for Hallamshire University Hospital or Sheffield Medical College in UK, and that is a working hospital when I was in United Kingdom. So after returning to India, my specialty was full of interventional endoscopic procedures, ERCP, enteroscopy, endoscopic ultrasound, and third space endoscopy. So all these advanced interventional and endoscopic procedures was my specialty, so which we are practicing. I came to India in 2008 and started the interventional department in KMCH and was heading the department for 5 years. And then I started my own practice and my own hospital in Coimbatore, which is SG Gastrocare. So we were doing all the advanced procedures of endoscopy, colonoscopy, polypectomy, stenting, stone removals from the bile ducts, and stricture dilatation, pancreatic duct stones, and various pancreatic cancers and pseudocyst drainages of the pancreas by endoscopic technique, avoiding surgical intervention. That is our main motto, to make it as much as possible patient friendly, cost effective, reduced mortality and reduced morbidity. So the mission and vision for us which we had was to deliver this to our own people in India in a cost effective and advanced manner with the skills and training what we had in abroad. So published many journal works and I've been conducting meetings for doctors and arranged international conferences in Coimbatore for doctors for inflammatory bowel disease. And as we know that we never lag behind the Europeans. That's what I learned after coming back to India in 2008. So we think that Europe is much better or America is much better than India. It's not. In fact, now we are getting much more better and they are going down by economy. You know, the cost is very high and NHS where I worked is not paying salaries to doctors and nurses nowadays. For past 3 months, many people are not getting salaries because of economic recession and the Ukraine war. But India is moving more and more ahead, getting more equipments, and I appreciate that SPMM has now put up a 32-slice MRI. And even the NHS is selling some machines because they cannot maintain those machines. And now we are buying machines and doing more and more work. So that's how the table tilts. We got all the technologies, all the consultants and all the specific skills which we need to treat people are coming up in India. It is only our mindset to grow. So I think we are growing taller than European countries. The Liberty of Statue was taller, but now Sardar Vallabhbhai Patel statue of unity, not liberty. It's the unity which is the strongest always and it is the tallest always. And similarly, I refer medicine to this because we are growing much taller than the Europeans, and the medical field and medical equipments and knowledge is expanding in India like galaxy. It's no end. So many doctors, so many well-trained people, so many teachers are there here. It's only you need to channelize and use these opportunities and facilities to train yourself as an expert. So those are some of the paper clippings and things which we have received awards and for the procedures which we did as first in Asia and also in India. So my topic is going to be on the practical tips, but before going into practical tips and more concentrating on gastroenterology and general medicine and all other topics I touch, this is what my outline of talk going to be. Basic science behind what we do and the practice points, what you gain and why do you need to be strong in your basic sciences, because nowadays basic science is very, very important. The molecular level and the microbiological level of knowledge is so much important to devise newer drugs, because previously we didn't have much disease and no equipments and less number of medicines. So we just have to memorize how this medicine, why it is used for, where it is used, that's it. But now once you know the molecular mechanism, you will be able to invent newer medicines, newer technologies to detect viruses, and because in fact we should be proud, we devised as at the earliest the COVID vaccine. And that was a wonderful, successful vaccine compared to the European vaccines. And European vaccines were more or less a failure, Pfizer. And it costed lots of complications, adverse side effects. But Covaxin and Covishield, the strong basic knowledge about the virus which they could do and use the standard technique of isolating it and using it with the adjuvant, they made a wonderful vaccine. That has come out because of the basic science knowledge which we have developed over a period of time. So basic science is very important, and when I was studying medicine as a basic science, we didn't realize the importance, because when you come to a medical college, the basic sciences teach us about the new concept which you will never understand because it's just fresh from the school, but using those techniques is the most important. How a cell works and where it works and how deep it works makes you to invent newer drugs and molecules which will be the future. Okay. So before going into it, I'll just say something about my field of interest, otherwise I'll forget myself as a gastroenterologist. But always as a specialist, I will not say that I'm a gastroenterologist, I will always say I'm a doctor or a medical specialist, because there is an interlink between every organ and every structure. You cannot just see the one part of the organ and say, this is normal, it's not my responsibility, because pain may be, for an example, abdomen pain may be related to, as you know, could be related to a chest infection, gastritis, ulcer, pleurisy, or liver infections, or cholangitis, and various other things. So you cannot detect even myocardial infarction can cause abdominal pain. So very important that just general medicine, it is impossible to be a good doctor. So அதுக்கு தான் வள்ளுவர் சொல்லியிருக்கார் ஃபர்ஸ்ட், நோய் நாடி நோய் முதல் நாடி அது தணிக்கும் வாய் நாடி வாய்ப்பச் செயல். What it means is, you instead of treating the symptom, so many nowadays because of pressure or things which they have not understood, if you come to a doctor, if you have pain, abdominal pain, you put a paracetamol, you put a pantoprazole, that's it. It takes 1 or 2 days for them to recover, give it, or some people doesn't improve because we have not taken the proper history, and also very important to analyze the chronology of the patient's symptoms. Only if you take a proper history, we will be able to differentiate between different parts of the body causing the problem, because we have a lot of equipments now. Previously we didn't have any equipments, we have relied on the clinical history to get the diagnosis. To confirm it, it's difficult, but now always I would say, if you listen to the patient, properly take history, and then use an investigation to confirm the diagnosis. For that you should have a sound knowledge of basic medicine. It's important for all specialties, including general practitioner or a consultant physician or a consultant specialist. So you have to see the whole body as one rather than treating it, because just treating a pain doesn't help you to diagnose the disease. It's a symptomatic cure. Treating the disease is the permanent cure. But you have to do both. Find the cause, treat it, and also use medicine symptomatically to relieve. Just giving symptomatic treatment alone is not your job satisfaction, or you have not done your duty because you have not fully evaluated the patient. It's very important for budding young doctors to know just giving a paracetamol for abdominal pain, and some people I've seen for cardiac chest pain, they have given written paracetamol and diclofenac without taking a proper history. So unless you take a history, it is impossible to differentiate between a small musculoskeletal pain or a myocardial infarction or a gastritis. So please do spend time, even though we are busy, but every life of the patient is very, very precious for them. If we become a patient, we know that if somebody is not taking a proper history of a good care, then we will realize that how much misery we are. So the same thing, we should be in the patient's shoes to understand that have we done the right perspective for the patient, taking a proper history, which is mandatory, and it's rewarding also. So when you diagnose, treat correctly, appropriately, the satisfaction and the happiness what you get is definitely higher and much more for the patients. So coming to the gut, so we'll see what gut is important thing. So any medical student can tell what is the surface area of the gut. Why I'm putting this slide is it's very important. The GI tract is the largest part of the body. So that's why I'm asking, because it's coming into contact with the external environment. So the only way in which the external environment can communicate with the body is through the GI tract and to the respiratory tract, and also through the renal tract, the holes which are open to the atmosphere. So all the three people are here who the organs are communicating with the external surfaces. But predominantly GI tract is the largest one, which is exposed and retaining the external agents inside the body for a longer period of time. So the interactions is very, very high. Unless we know exactly about what is the GI tract doing to our system, we will not be able to understand the basics or how to give importance to these organs. Anybody, what is the surface area approximate, or any comparison you can say? Okay, so I'm not going to waste time, I'll just go back. So it is equal to 300 meters square, which is equal to the surface of a tennis court. It is so big. 2 tennis courts put together is the surface area of the intestine. So that's a large area, and you can see here it is covered with the villi, the intestinal villi, the small intestine. You can see here the newer technology which we use to see the villi in the textbooks. So that's the endoscopic appearance of the GI tract when you switch into narrowband imaging, which is filtering the color into blue and green only. So the colors, you know that 7 colors, you filter them and use only the blue green. You can see the Peyer's patches. The first year medical students or all students will understand that the Peyer's patches are the patches of lymphocytes concentrated in the terminal ileum, which we can see by naked eyes. So the molecular level we can see, which helps us to decide about whether there is an infection, inflammation, injury on the surface of the intestine. So that's how it looks like, and it's amazing to see that. It's like a coral reef inside the intestine, and when you put water into it, you can see how clearly the intestinal mucosa appears like velvet of villi appearing on, and you can see any damage to the villi also or inflammation. This is a normal looking one, but if there is inflammation, injury, bleeding or blood vessel damage, I can see by using this narrowband technology very easily without biopsy or looking into histology. But we do that for confirmation, but we can identify which area is having problems. So, and second point I would like to say is it has the largest surface area. And how many of you know that this is the largest organ, second to the brain, harboring the maximum number of neurons. So brain has nearly 86 billion neurons. and the intestine and the GI tract has 600 million neurons. That's why we call the gut as the second brain. So whenever you see, if you're going to unusual circumstances or any peril you meet with, you will say, suppose you're going in a path, you say, இந்த பக்கம் போலாமா அந்த பக்கம் போலாமா சொல்லுவாங்க, என்னோட gut feeling says I will take the right. So it never says my heart feels like or my kidney says I should go like this. No, you always say my gut feeling, because you already know that the gut has the highest number of neurons in the body, because it acts as a second brain, independent second brain, and it's got the enteric nervous system, which is a separate nervous system. It can function independent of brain. It controlled by the brain, but it can still work without the brain also. Even if you defunction or transect the spinal cord or damage the brain, intestine still works because of the sustained capacity of the enteric nervous system, which is a intermingling of neurons, which is located in the submucosa and myenteric areas, that is in the muscle layer. So submucosal plexus and myenteric plexus we have. That is the histological appearances of when you do in the lab, where this area of myenteric cells are located. So you can see why I am saying is it's very important. I'm not going to bore you, because these microbiological values has helped us in treating the patients as well. See here, there are different types of neurons, inhibitory neurons, excitatory neurons spread all over the intestine, which either by control of brain or without brain they can work completely. So it's very important. But what makes them to contract without the brain? So you need always something to activate the cells. What is that to activate the cell here? Anybody knows? How is cardiac muscles functioning? How the electrical impulse comes from? Where does it comes from? So yeah, somebody says it's SA node. Correct. So that's called the pacemaker of the heart. Do you make the pacemaker of the intestine? So who is the pacemaker of the intestine? So they are called the interstitial cells of Kajal. So they are another type of peculiar cells where their high flow of sodium potassium pumps helps us always to keep active, and they communicate or connect to the enteric nervous system. So they keep on sending the impulses spontaneously so that the intestinal movements are maintained. So why is very important? Because like SA node dysfunction, we say sinus arrhythmia or sinus dysfunction or sinus block, because it does block means then the cardiac rate goes down. So the other pacemakers has to, like AV node or other junctional rhythm has to take over. Similarly, when the interstitial cells of Kajal does not function properly, as I told you that you can see the interstitial cells of Kajal are saffron in color, and they're communicating with the enteric nervous system and also to the smooth muscle through the channels of calcium. So that opening of the calcium channels helps to contract the intestinal smooth muscles. So why is it important to know this interstitial cells of Kajal? What is the clinical point? We knew, as I said, knowing the basic science, how it helps in clinical practice. Because we know that many people suffer from constipation or delayed movements of the intestines and end up in bloating, distension of the stomach without a known cause. But these cells cannot be seen by endoscopic technique. You can take biopsy, do electron microscopic studies, assess the number of cells and the muscle layer of these neurons. In these patients, where they have been termed as irritable bowel syndrome, that means doctor doesn't know what is it, and the patient is irritated, and sometimes doctor is also irritated because you cannot find a cause. They keep on coming to you every day bloating, sorry, enna marudhu kodutha seriya maatengudhu, vairu ubbuma irukku, uppusama irukku. The reason is the intestines are not moving properly and they are having constipation, because we found that either these interstitial cells of Kajal are not working properly. Realized. Sorry, I didn't realize that I was obstructing the view. Hope my audio is also clear. I didn't check it prior. Are you able to hear clear? Okay. So once I know that my video is obstructed, I have to check the audio also. Okay. So now we are using certain drugs to stimulate this pacemaker cells of the intestine to move the intestines properly. Those are the receptor stimulating drugs we use called prochlorpride, which is 5-HT4 receptor agonist, which increases the intestinal movements and also the firing of the interstitial cells of Golgi. Like what we use certain drugs for bradycardia in cardiac sinus node dysfunction, like ivabradine. These drugs can allopentanol stimulate the SA node. So now we found that the intestine also as a pacemaker, you can also stimulate these cells, but sometimes some people have very less number of these cells, or these cells are very much dysfunctional where you cannot treat them. So they end up in permanent constipation. So once we know the signs, we need to find out a technique, and now we are coming up with microchips of interstitial cells of Kajal, like working like a pacemaker of heart. We can implant in the intestine. The research is going on so that these patients will benefit. Without understanding the basic signs, we will not come out with a solution for the patient's problems. So it's very, very vital that we understand why is this happening, how the functions of the body does until the microscopic level, and address the problem faced in that point. So very important. The next question is, which is the largest immune organ of the body? So we have multiple immune organs. We know that lymph nodes, tonsils, appendix, Peyer's patches. Peyer's patches are the ones which I showed you on the screen when we did a colonoscopy, entering into the ileum, and then you show the villi-like structures. Intermixed with them are the Peyer's patches, which are nothing but the lymphocytes aggregates, which are the defense mechanism in the ileum, tackling the bacteria entering into the systemic circulation. But we thought spleen may be the largest, or lymph node or thymus was the largest, but ultimately the GI tract is the longest organ in the human body, or largest organ in the human body, carrying so many white cells and also lymphocytes to the entire GI tract. So we call it as GALT, gastrointestinal tract associated lymphatic tissue. So it is so much spread all over the intestine, because as I told you, the reason is it is the only structure exposed to the atmosphere continuously. So you need a continuous defense entire system. So this is the largest immune organ. Why should we know that this is the largest immune organ? What is the benefit? I'll tell you why we should know about the largest immune organ, because everything comes from the immune system, in fact fighting against the bacteria or fighting against our own cells or autoimmunity or inflammation. And the second question raises is, who is more in number in our body, bacteria or our cells in the body? Anybody knows who is outnumbering who? Any guess? Only yes or no? So everybody knows. Good. Bacteria is more in number than the number of human cells, because they are tiny in nature, so their more number of cells can be accommodated. So they are 3 times more in number than the human cells. So we are at the mercy of the bacteria. So the bacteria lives throughout the GI tract, and they interact with our largest immune system constantly every day. So they are like seated on the entire surface of the GI tract, floating on the mucus secreted by the goblet cells in the intestine. The mucus also is containing 2 or 3 layers. The top layer is a sliding layer like an escalator, which keeps on moving. All the toxins, chemicals, pathogenic bacteria keep sliding. And the second layer of the mucus, which is a fixed layer, which attaches to the villous surface of the gastrointestinal tract and anchors the mucus layer to prevent any damage. So this is the basic infrastructure of the GI tract surface when it is getting exposed to external agents or bacteria. Why is it important? So you can see here, a lot of things happens in the intestine, as I told you, when the bacteria interacts with the GI tract. So you can see here a lot of bacteria on the surface of the intestinal epithelium. Forget about the name, it's called Faecalibacterium prosnoski. It interacts with the dendritic cells. You've not heard about the reticuloendothelial cells, which are the macrophages situated in the tissues, which is nothing but the dendritic cells. They have a constant communication with the bacterial content and the bacterial products or the bacteria in the lumen. So there is a two-way communication between these two. So only if it is a friendly bacterium in the intestine, these dendrite cells don't activate any inflammation, or it activates the inhibitory inflammation, that it inhibits the inflammatory process. So if you have more number of Faecalibacterium prosnosi, then it's called peacekeeping bacteria. It says everything is under control. So don't do any fights or anything. It's like a border, like India-Pakistan border. If you see our Jawan's uniform, the firing will not be there from the behind. But if you see a Pakistani soldier standing on the other side with a different color, immediately our Jawan starts firing. So that same thing happens in the human body. So if you have more number of good bacteria, the interaction between our immune cells and the bacteria is so good that our intestine is always happy. Otherwise, your stomach will be, or intestine will be always rumbling. The bacterial contents can produce a lot of inflammatory reaction, and those reactions can cause various other problems, which I am going to say. That's why I said, why is it important to know that so much of bacteria is living in the gut? There are 1,000 species of bacteria living in the GI tract, and only 20 species can be isolated, because we don't have any other culture medium to grow the rest of the 980 bacteria to grow. So those mediums are available. Their requirements is still not able to be studied by the human people. So still going on, research going on. So these are those bacteria which are living from the day one after you are born, and that helps to give a healthy environment in the bacteria. So the factors determining the gut-brain axis. So we have a new concept called gut-brain axis. As I said, the gut has the enteric nervous system, and the brain also has this same system of neurons which they communicate with each other. So how they can do this? So you can see here the bacterial products are interacting with the epithelial cells, the intestinal cells here. So pointer, I cannot get it there. So you can see the bottom side is the intestinal luminal side, where the bacteria are living, and it takes our food and metabolizes, ferments, and produces short chain fatty acids or neurotransmitters. You know, there are mainly 4 neurotransmitters which functions in the human body. Noradrenaline, acetylcholine, dopamine, GABA, and glutamate. So these are the main 4 or 5 neurotransmitters. So bacteria also produces the same type of neurotransmitters during the metabolism. So they can directly interact with the neural cells which is coming from the enteric nervous system, and the messages can be going to the brain. So if you have more 5-hydroxytryptamine or serotonin producing bacteria, then there will be an interaction in the brain, which I am going to show you. So there is not necessary that brain only produce neurotransmitters. The bacteria also producing neurotransmitters. This can have an impact on the body. So all of which are play in your mood. So the type of neurotransmitter produced in the body. Serotonin activates your amygdala and different parts of the motor system of the body. Keep your mood elated. So you can see so many psychiatric patients receiving antidepressant medicines. The majority of them which they come to the clinics receive SSRIs. Have you heard about SSRIs? SSRIs, serotonin reuptake inhibitors. So what you do is you give a drug to prevent the reuptake of serotonin in the neuron, so that the serotonin concentration increases in the neural junction and keeps on activating you. The similar effect can be get when you have good bacteria in the gut. So that's why we eat certain type of foods which can produce more serotonin and calming neurotransmitting agents. Or otherwise, you would have also felt you had something in the parties or marriage halls or unhygienic food, or again fast foods or beverages, then your gut will be always be agitated, your mood will also be agitated, and also you can say, "Nalla saapta enakku romba mandama irukku." How do you get that feeling? And mandon solraliya, that's mood. That mood goes down because you have fed bacteria which are producing neurotransmitters which are depressing your brain. So, vaya katna, vaitha katna, kudal nalla irukkum solluvaanga. First enna udal nalla irukkanona kudal nalla irukkum. ஸோ அதுதான் ரொம்ப ரொம்ப முக்கியம். ஸோ அந்த குடலை நல்லா இருக்கணும்னா அந்த பாக்டீரியா நல்லா இருக்கணும். அந்த பாக்டீரியா நல்லா இருக்கணும்னா நீங்கள் என்ன சாப்பிட்றீங்களோ அதுதான் முக்கியம். ஸோ த ஃபுட் வாட் யூ ஈட் அண்ட் இட் டிட்டர்மின்ஸ் வாட் யூ ஆர், வாட் யூர் மூட். ஸோ இட்ஸ் வெரி வெரி இம்பார்ட்டன்ட். இது அந்த காலத்திலே சொல்லிட்டு போயிட்டாங்க. அதனால தான் நமக்கு வந்து எல்லா இடத்துலையும் முடிச்சதுக்கப்புறம் தயிர் கொடுக்குறோம். தயிரில் வந்து we have lot of lactobacillus bifidobacterium. These are the bacteria which produces good amount of positive neurotransmitters and also helps stabilize the mood. So very very important to know that. So instead of using antidepressant medications, you can use certain bacterial elements to give upregulating the mood in the brain. So keep your gut bacteria right and keep your mood right. So it's, as you know, unless you know these sort of basic sciences, then we will not be able to come out with new drugs or modify. You should know what to modify. Without knowing what to modify, how will you do research? So the more interesting points are where is these things happening and how is it happening. So what else that bacteria produces? So these are all short questions for undergraduate students and in fact postgraduate students also. So not only the gut bacteria produces neurotransmitters, it can produces short chain fatty acid, which is very very important. I'll tell you why. And also secondary bile acids. What are the primary bile acids? Bile acids are produced, bile is produced by the liver and they are conjugated with the sodium salts and then become taurocolic acid or glycocolic acid conjugation and become quinodeoxycholic acid and taurocolic acid combinations producing secondary bile acids. So the primary bile acids are lithocolic acid and quinodeoxycholic acid, and they are broken down into lithocolic and deoxycholic and further down. So these are secondary bile acids which are broken down by the bacteria. It's very very important that unless these bile acids are broken, they cannot be recycled. Once the bile acid stays longer in the intestine, they injure more and produces more damage to the colon and predispose you to cancer. And similarly, when you don't have bacteria producing short chain fatty acids, what do you mean by short chain fatty acids? It's nothing but fatty acids which are having only 6 number of carbon atoms. More than 6 is medium chain, less than 6 is light chain, and more than 20 is long chain fatty, very long chain fatty acid. So these short chain fatty acids functions as a nutrition for the intestines because short chain fatty acids directly are taken up by the colonic epithelial cells for nutrition. Not only blood supply is important for nutrition or oxygen is important, short chain fatty acid is the major nutrient for the colon and the intestine, especially colon. So it's very important that these bacteria which is producing these substances are kept in the body in right. So these are some more basics. What is fatty acids? The fermentation process by which fatty acids are converted into various short chain fatty acids. You can see here. It's a busy slide, but it shows how short chain fatty acids, which are the 3 fatty acids, acetoacetic acid, acetate and beta hydroxybutyric acid. That's we know that the ketone bodies they are called because they have a ketone group also. So they directly can stimulate the microbiological, they can interact with the nuclear area and suppress the inflammatory mediator production. So cytokine suppression and also interleukin production can be suppressed directly by the short chain fatty acids. So they block the pro-inflammatory response and they have an anti-inflammatory effect. So the more anti-inflammatory effect, the less the injury to the colon and less irritation to the bowel, less production of cancers. So how can you get lots of short chain fatty acids. What is the practice points? This fermentation of dietary fibers. You give lot of dietary fibers, good bacteria are produced, and they ferment the fibers and produces short chain fatty acids. So how to enhance short chain fatty acid production? Eat lots of peanuts. Peanuts contains lots of short chain fatty acids. Even if bacteria are not producing, or if you don't have good number of bacteria producing short chain fatty acid, eating peanuts gives you lots of short chain fatty acids, which prevents from having cancer and also inflammation. And the most important thing is taking curd along with that also. The curd has bacteria which helps to produce more short chain fatty acid. So when you don't have the right type of bacteria in the gut, there is a constant fight between the gut bacterial contents and the intestinal content along with the immune complexes. So there is always a fight. Whenever there is a foreign agent is coming, like when you're in the war, the more number of enemies are coming, the more deployment of our soldiers will be there, and more damage and destruction will be there. Similarly, you always expose wrong bacteria, our defense cells are fired up, continuously attacking the bacteria, and you have always a pro-inflammatory condition. That means you are injuring the intestine, so the intestine becomes leaky. That you know that the intestinal cells are held by tight junctions, actin, myosin complex, desmosin, and various other connective tissue proteins. So these are getting destroyed, or the production of these tight junctions are inhibited by the bacterial products and the inflammatory cytokines, so that the contents of the gut lumen enters into the systemic circulation. That's why when you get food poisoning or gastroenteritis, you do feel like shivering, feverish. Even though the problem is in the gut, why should you develop a generalized systemic reaction? Because these bacterial contents are escaping into the systemic circulation because of the leaky gut. That's what the new term is called, leaky gut syndrome. Not only in food poisoning, always when you have a unhealthy bacteria, you always have a permanent leaky gut, and the problem of permanent leaky gut is significant because you can see here the lipopolysaccharides and the bacterial polysaccharides are entering into the systemic circulation. They can, first point of entry is into the liver. The liver is also getting exposed to these chemicals or interleukins. The liver is getting damaged, and also these bacteria can produce alcohol. The alcohol shown is here is not drinking alcohol. The bacterial content as such on fermentation can produce alcohol, which can damage the intestine, and that can produce continuous injury. So what is the consequence of leaky gut? Previously people doesn't know that recurrent sinusitis, recurrent asthma, recurrent arthritis was due to an immune related damage, but not coming from the gut. But actually all this process started from leaky gut. When you have a leaky gut, the bacterial contents are keep on entering into circulation. The interleukins and the chemicals produced by the white cells and lymphocytes are entering into circulation, and this immunological system does affects all parts of the body. And in fact, the leaky gut syndrome is responsible for mood depressions, attention deficit disorders, anxiety, and also various paranoid situations. So whenever you see more of these bacteria continuously damaging, then you get leaky gut. So that's why we organize a conference about the systemic interaction of the GI tract with various other organs, and we had a very good theme on single focus theme from GI tract to various other organs getting affected. So the practice point is using bacteria as a treatment. That's called probiotics. So as I told you, some of the bacteria which containing good effect on the gut can help you to reduce the inflammation. So probiotics are nothing but live bacteria which have a good effect on the gut. Prebiotics are nothing but the bacteria eats these food and grows. So food which is helping the good bacteria to grow are called prebiotics. So there is another new entity which we used is the bovine colostrum, the chimbal solvanga, adilinde edukakuriya proteins. Why is it important? We used it for a novel treatment. So the bovine colostrum contains various components of the peacekeeping immunological system, proteins, nutrition, vitamins, enzymes, and transforming and colony stimulating factors. So we have a patient who had a combined variable immune deficiency syndrome. That means they cannot produce immunoglobulin G and immunoglobulin A. Predominantly GI tract and respiratory tract are the system getting affected because of reduced productions of the immunoglobulins due to a defect in the maturation of the plasma cells. So these patients are dependent on IV immunoglobulin permanently. So you cannot have any other option. Otherwise, they will get recurrent respiratory infection, chronic granulomatous infections, and also recurrent GI infections, inflammatory bowel disease, and also lymphoma and malignancy. These are the various complications of common variable immune deficiencies. Immunoglobulin costs you more than 12,000. Every 3 weeks you have to give, because the half-life of immunoglobulins are only 3 weeks. So you have to keep on giving. The cost is phenomenal. People cannot do it. I had a patient who had a same problem, CVID, and he was been having this problem for 10 years and not diagnosed, but he lost nearly 30-40 kilos, and he came to with a dying situation with a dehydration, sepsis, infection, and significant diarrhea and weight loss. So we found that he had this CVID, but we didn't have an option. First 3 treatments we gave immunoglobulins. After that he didn't have the money to continue. So we stopped it, and he said, I can't pay, and we stopped it. Initially for 3 months he improved with the immunoglobulins, and after stopping he became worse. So then we realized that why can't we use this bovine colostrum, which there was coming up in the market, and use that bovine colostrum which contains all the immunoglobulin components and proteins. So we started giving him, and he started improving, because the leaky gut is the main problem in this individual, and also recurrent infections. The immunoglobulin content has helped in neutralizing the bacteria and infections which didn't respond to anything else. So this was published in our American Journal of Gastroenterology, and 2 months ago I published in our Indian Society of Gastroenterology meeting held in Jaipur. And that was the first of kind where we used oral immunoglobulins and oral colostrum type of proteins for treating such type of patients. So only when we know these biological signs happening inside the intestine and able to think laterally about a common problem, then you will be coming out some new ideas and new research. That's the main point of talking about it. And as you know, the constipation also can be produced by bacteria. Methane producing bacteria can inhibit the enteric nervous system and cause constipation. So changing the bacterial content of the intestine can stimulate the GI tract. So last few interesting case presentations, and then we'll quickly go off, finish in another 5-10 minutes. So this is about a patient who had recurrent diarrhea and blood in the stools, not responding to medical treatment with antibiotics. What do you think? Chronic diarrhea with blood in the stools. So one thing is about an infection. The other thing is you can see this type of significant inflammation in the bowel, which is inflammatory bowel disease. It's called ulcerative colitis, where there are significant ulcers and inflammation happening continuously throughout the colon like this. So your touching point is whenever the patient is having chronic diarrhea and more blood in the stools, you should think about inflammatory bowel disease apart from infection and cancer. So these are 3 common. So this is becoming more increasing in number in India. And you know that inflammatory bowel disease are 2 types. One which affects only the colon, the other which affects the entire GI tract. So you have to differentiate between IBS and IBD. IBS is there is no injury to the mucosa, but the bowel is irritated and produces the same symptoms as IBD without blood in the stools. IBD is nothing but there is a continuous inflammation of the intestine because there is a constant overactivity of the inflammatory cytokines in the intestine. That is, as I told you, triggered by the abnormal bacteria, abnormal food we eat, preservatives, chemicals, and fast foods. Continuous inflammation is persistent and they suffer a lot. So whenever people with a genetic abnormality to control the inflammation. When they're exposed to abnormal environment with bacteria, this inflammatory cytokine starts working very severely on the third slide, and you can see the microscopic inflammation is transferred to histological inflammation, and the histological inflammation later becomes subclinical inflammation, and then you can see the mucosal injury. When they becomes very severe, you have to resect without doing any other treatment. So that's how the cycle goes. Cycle of events, and we are the first one to use inflammatory bowel disease clinic in Coimbatore and set it up in 2008 after I returned from UK, because Europe has so many of these IBD patients, but we didn't have, but we are catching with them because more urbanization and more fast foods we use or European type of food we eat, we develop IBD or significant inflammatory bowel disease. So I showed this IBD is increasing in India, especially in Coimbatore and around Coimbatore, Tirupur and Pollachi, and again published in 2011 in Indian Society of Gastroenterology. We had nearly 160 patients diagnosed with IBD. So it's not new disease, it is there, and we need to just identify. Think whenever a patient has chronic diarrhea, blood in the stools, abdominal pain, not responding, you should think about IBD also. So simple test is there, fecal calprotectin. These are proteins produced by the white cells. They are excreted in the stool. If it is very high in number, you suspect, and if you suspect, you have to confirm the diagnosis. You can confirm the diagnosis by colonoscopy, biopsy, and then treat accordingly to suppress the inflammation with immunomodulators or immunosuppressives. So same history. This is an elderly patient. So whenever you see a 50-year-old male with recent constipation, intermittent mixed with stools, a smoker, because he thinks that he's got hemorrhoids, that's the most commonest condition, piles we call them, and they take treatment without consulting the doctors, but end up in later complications. So always, whenever there is a new onset of constipation or blood in the stools above 50 years, always think one diagnosis. What is the one diagnosis? Colonic cancer. So you have to think about colonic cancer, and it can be prevented. The new techniques is that colon cancer doesn't come like once out of a blue suddenly. It comes from polyps, as you know. The polyps are small overgrowth of mucosal tissue, unregulated growth. They keep growing from small stages to the bigger stage and become a big polyp. So now you can remove these polyps by endoscopy technique and prevent a cancer. So preventing a cancer is very, very big task, and rather than treating the cancer, we are preventing the cancer by the new technology which used. So you can see here, this is the polyps. It is not turned into a cancer, but you can see here it has a stalk. It looks like a mushroom, and they grow, outnumber the blood supply, and also they become bigger and bigger and infiltrate deep into the wall and then become a cancer. When it becomes cancer, up to first stage we can do by endoscopic mucosal resection by endoscopy, or otherwise if it goes bigger you have to do by a surgical resection. Here we can see, here I am using this electrocautery and laser technology to cut the polyp completely, not even a single drop of blood. So this is the new advancements in the gastroenterology field, where we can remove cancers or prevent cancer, so there is not even a single drop of blood, but the stalk is too big and the polyp has two heads, so we did resection twice, and then complete removal of the polyp was possible. So you can see here it's completely gone. It's very, very important that once you know this sequence of events, because from a polyp to cancer, it takes nearly 6 to 7 or 8 years. So by the time when you do this colonoscopy, if you find the polyp, you can remove them, you prevent a cancer. That's why Europe says anyone is above 50 years of age has to compulsorily undergo colonoscopy so that you prevent a colon cancer. Because colon cancer is the second highest cancer but now highest number of cancers is due to colonic cancer, overtaking the lung cancer nowadays. So you can prevent them by just doing a colonoscopy, because you have a long interval from polyp to cancer. So you can break that cycle and prevent the patient from having the cancer. So also we can use Ovasco clips like this to take the polyps off. It's like a jaw-like clips by endoscopic technique. So you can see here, this is the one which we published, and also this is the first in the world of kind, where we used a newer technology to remove this polyp, which is very close to the duodenum in the second part of the ampulla, which if you have to remove by Whipple's procedure, which takes a lot of money and also a lot of cost and morbidity. But we did it within 45 minutes. We completely removed the polyp and applied an Ovasco clip onto the surface of the pus, resected polyp area, because it takes a full thickness. You can see here the clip is infiltrating into the serosa of the intestine, and now our clip chips off the entire mucosa. Now you can see the clip is gone, the polyp is gone, there is no cancer. It was a neuroendocrine tumor with mild to moderate grade of dysplasia and going in for malignancy. So we can remove such type of tumors by endoscopic technique even in the small intestine or large intestine. Full thickness resection is possible. Normally we do mucosal resection, submucosal resection. Now we do full thickness resection. The entire structure of the intestinal content can be removed. Why this is important? Because I published this again in International Society of Gastroenterology, where we showed that out of 1,000 colonoscopic procedures we did, we picked up 170 colonic cancers and 168 polyps. So 168 polyps we removed and 168 cancers we prevented, but 170 had colon cancer also. So it's showing a very high incidence, around 10 to 15%, which is equivalent to the Western world. So don't underestimate colon cancer in India, because it's the tip of the iceberg and people are not realizing or not aware. Okay. So we quickly, this was done in our hospital and it was published, where we removed the tumor by endoscopic technique. So in fact we can remove tumors in aged people also, and we did stenting and also removing the strictures from the large and small intestine even in 96-year-old. So coming to a few, 2 or 3 cases, quick cases. Can anybody tell quickly what should be the possible diagnosis here? Out of the box, as I said, he was referred to me with abdominal pain and cramps in the abdomen. So as a gastroenterologist, I could not give just a painkiller and go, or a proton pump inhibitor to go. He, taking a good history, he said, pain is not only in abdomen, all over the body. So again, he had myalgia, tiredness, but no viral infection. But he was treated with antivirals, antibiotics and various other drugs. Other tests are all completely negative, nothing to worry. But he had a sedentary life. The only history is he had some drugs for his lipids and no significant history. Anybody can say quickly? Because I'm running out of time. I don't want to take much of other speakers' time also. It's very important clinical points I just want to say. I am just keeping on another 5 minutes. So what would you think generalized myalgia? With one clue is, you can see here, he is on some treatment for dyslipidemia. Dyslipidemia means hypercholesterolemia. The cholesterol levels are high. Can you interconnect those two? So he is on, what is the diagnosis? It's again I would say some of the tests shows SGOT, SGPT, CPK elevated. CPK's creatine phosphokinase comes from the muscle, which is high. SGOT also comes from the muscle and SGPT from the liver. So do you think he's got a liver problem? All the liver workups are completely normal. So it is statin-induced myopathy. You know that the drug which commonly used, every other person is nowadays using atorvastatin, rosuvastatin or statins, which blocks the cholesterol synthesis. So drugs which used can produce side effects like muscle pain, body pain, generalized cramp of the abdomen. So unless you ask, you will never get the history. Never forget to ask drug history in the patient. There's so many drugs which can cause complication. Each and different clinical situations are there, which we'll talk about in another session. But in this session, this drug has caused this problem. How does statins produce pain? Because you know that respiratory chains is the final end product of production of ATP. So where the electrons are transported from 1, 2, 3 chains in the mitochondria, and finally the mitochondria produces ATP. The statins inhibits the electron transport chain. Probably if you are well versed in biochemistry, you might know that respiratory chain or electron transport chain are the main function in the mitochondria for energy production. And if that is affected, then ATP levels are reducing, and it also inhibits the coenzyme production. Coenzyme Q is one another enzyme in the mitochondrial electron transport chain, which can produce significant myalgia, body pain, and the metabolism of the statins can produce lactones, and the lactones are the ones which blocks the respiratory chain. So knowing this only helps you. These are all in the molecular level. Only if you know that, then you will say that this is statin caused problem. Stop the statin. He completely recovered within 1 week. So which is the safest statin? We have so many statins, atorvastatin, parvastatin, rosuvastatin. Rosuvastatin is the only one which is not having any inhibitory effect on the mitochondrial respiratory chain. So you can use safely this. And various other causes of myalgia and tiredness, always keep in mind viral infection, hypothyroidism, and connective tissue disorders, and B12 and vitamin D. Always keep in mind, that's for your points to remember. And again, this lady comes with cough, pain, and abdominal cramps. Again, referred for the same problem, abdominal cramp and cough, pain. Okay. So the diagnosis was hypothyroidism. Don't forget to measure TSH whenever they have cough, pain, or significant pain, apart from ruling out other problems related to causing the pain in the legs. Another history is patients with recurrent ascites. If they exclude cardiac failure, liver failure, and renal failure, unexplained ascites, always check thyroid functions to exclude hypothyroidism. So this also had thyroid related issues or hypothyroidism producing ascites. He was referred to me for liver failure because of ascites. So by doing a TSH, we found that he had hypothyroidism. So I think we have a lot of other cases, interesting cases and everything to discuss. It's endless and there's a lot of interesting ones to kindle our brain. And I think I am running out of time, so I'm finishing off, and I'm not going to go out with all these other case histories. So a few more cases are there, but I will finish. So one more, last one will just go. So this one you have never to forget to ask patients when they come with recurrent bloating or recurrent distension. They keep on saying this, as I told you earlier, whenever they have interstitial cells of cardiac dysfunction. But the other one, most common thing you have to remember, many are referred to me for IBS-like treatment. And don't forget to ask another important history is dairy products. When you take dairy products, if the symptoms getting worse, then it is nothing but lactose intolerance, where there is lack of enzyme lactase, which metabolizes the lactose. So if you have lactase deficiency, the lactose is not metabolized, the bacteria takes up and produces gases and have problems. In our center, we detected that the patients referred with IBS had 32% lactose intolerance. So if you detect lactose intolerance, stop milk, they are not IBS patients, they get recovered. So asking the history is important. Like what I said, asking about the drug history, asking about a dietary history, very, very important. Last one, in females, never forget to ask one very, very important, because this patient was referred to me with significant vomiting and nausea for 2 weeks. Don't underestimate any females, and they have no history of food poisoning, but she was treated by antibiotics, everything done, nothing works, keeps on nausea and vomiting. She referred for endoscopy. Only one question was not asked to us. You are asked about, never asked, again never told, is our menstrual history, because she had amenorrhea and she was pregnant. That was the reason for nausea, vomiting. Keep on giving medicines will harm the fetus and also cause more problem. Maybe funny, but it's very, very important when you face them clinically. Without asking question, don't get embarrassed by treating patients who's pregnant with plenty of drugs and damaging the child, and also end up in litigations. So ask questions, drug history, dietary history, menstrual history. Never forget, always you will get some clue. Thank you very much. And even though I exceeded the time, I apologize, but I thought it's some valuable information which I can share with the medical students in the future, that they take these some take-home messages, and also the molecular concepts I have to explain a bit longer, and the newer technologies. And I hope it was interesting and made some slides so that we don't sleep at all. So I leave now, and I leave the podium for the other speakers to share their own experience for the students' benefit. Thank you very much.
Thank you for enlightening us with your knowledge, sir. As we are running short of time, doubt clarification can be done later during the lunch. Now, I request Mr. N. Ashoka, Founder and Director of Spark Engineers Private Limited, to present the memento and honor Dr. M. Ganesh, Chairman and Chief Gastroenterologist, SG Gastrocare, Coimbatore.
Next, we have Dr. S. Palanirajan, MD DNB Nephrology in Apollo Hospital, Chennai. A native of Madurai, has the credit of performing more than 6 lakh dialysis sessions and 750 renal transplant procedures, which include many high-risk cases and cadaver renal transplantations. He started Shasta Dialysis Center in Madurai, running the unit with 17 hemodialysis machines. He also launched the first dialysis van inaugurated by Dr. APJ Abdul Kalam in 2013. In less than 4 years, this unit has completed more than 1 lakh dialysis sessions. Sir, I request you to kindly come up on the dais to speak on the heading Chronic Kidney Disease.
Good afternoon. It is supposed to be a morning session anyhow. And I thank and congratulate the chairmans, trustees of the SPMM hospital for this wonderful achievement. And I hope they will be soon going for a medical college. So you can book your PGs or UGs for your children now itself with the chairman. I congratulate and expect it, sir. Thanks a lot. And it's my gut feeling and your gut feeling that I should be sharp and crisp. I think I'll stick on to that one. First slide. I have titled, Is it a bolt from blue? That means a clear sky, you don't expect a rain. All of a sudden there is a thunderbolt and you get a torrential rain. How do you manage? And the chronic kidney disease, people think it happens like that. The people, I mean the patient who is sitting in front of you and the practitioner feels the same. Next slide. This one? I think most of you think the Salem Medical College started in the year 1990, that is a physical structure. But I belong to the first batch of Salem Medical College in 1985 and we were posted in Madras Medical College. There were a batch of 75 students and I belong to the first batch. Likewise, in 1990, I was the first special trainee in the Department of Medicine in Salem Mohan Kumaramangalam Medical College Hospital, where Dr. Kalanidhi was HOD and Dr. Muruga Pandian, senior cardiologist. We used to work together for hours in the hospital. But for the first time, I'm standing here to talk. I think it is scientific talk. Thankful to the management of SPMM hospitals and Dr. G. Sivaraman. You might be sitting in your practice telling a patient, I have a vomiting of 1 week duration or I have a breathlessness of 2 or 3 days duration, but you call for the investigation, urea is more than 200, creatinine is 25, and you say the patient needs a dialysis and thereafter he will go for a transplant. This is the thing that we discuss. For a medical practitioner, it's simple, but for the family who is facing this ordeal, it's unimaginable from the social, familial, and psychological point of view. How do we diagnose renal disease in general? There are 3 or 4 things. One is a urine test, but I think it is abundant nowadays. It is very cheap and very easily available. And not only that, you call it as a urine routine, so it has become almost a routine. We don't look into that so avidly. Blood urea and serum creatinine, common parameters, and used for still the diagnosis of a renal disorder. And ultrasonogram abdomen, really a good investigation, non-invasive, non-radiological hazard, and easily available. But how many of you get into the history? And I should say, sitting and patiently listening to the history is very important to make a diagnosis between acute and chronic renal failure that is being lacking in many setups. Very rarely, other investigations like hemoglobin, uric acid, calcium, electrolytes, these are called for and these are used to diagnose renal disorders. But they play a major role. When albumin leaks into the urine, it indicates a glomerular disease, nothing else. You cannot say it's a trace albumin, 1+ albumin, so you can ignore, it will go, it will come. You cannot have excuses on that. It indicates a structural glomerular disorders, except in a child where it is a minimal change disease, but still it is a renal disorders. And the common cause of albuminuria in a young adult is IgA nephropathy, which is a very deadly disease. And in diabetic nephropathy, if you see an albumin, that indicates already structural damage has set in. And hypertension, that albuminuria may come, may go, but it also indicates a glomerular disorders. So that very simple test which costs around 60 rupees to the patient tells about a renal disorder. Agathin alagu mugathil theriyundra mari. If there is a urine albumin, there is a renal disorder. But we tend to miss it. Why do we miss it? In the sense, albuminuria should present as an edema. Well understood. But in early stages of albuminuria, the person develops only travel edema. In the sense, when he travels for 6 to 8 hours in a sitting position and gets down from the bus or a car, he notices an edema, he ignores it and he walks, it goes away, and with that albuminuria related things are left. When you sit in a OP and ask for edema, they say it is only for 1 month or 2 months, but when you put this question of travel edema, definitely in 90% of the people with a significant disorder to whom the edema is for a short duration by a history, but a detailed history will tell there isn't travel edema. We even now think that travel edema is physiological. Because we sit for a long time, we develop edema. It is not true. Maybe in a very elderly person, 70, 80 years old, that may be ignored, but in a young person, when he gives a history of travel edema, that indicates his renal disorder has started at that time. So please make in your history whether he gets a travel edema. Next. Why this urine albuminuria is not given that much importance? Because we don't call urine albuminuria as a protein leak in the urine. Commonly we call it as a uppu sattu. There is no uppu, there is no sattu. But still that albumin in the urine is called as uppu sattu. And the easy remedy given to the problem is dietary salt restriction. When there is an albuminuria, there is a retention of sodium and water, so there is an edema. In a case of albuminuria, when you tell the patient he has a uppu sattu in the urine and the common remedy is restrict on dietary salt, the edema disappears. He becomes free from the edema. So we think there is a diagnosis, there is a cure. But that is not the truth. The albuminuria continues, keeps on, goes up. But the edema is masked because of the dietary habit. When the albumin leaks out of the glomerulus, it is engulfed by the renal tubules, it is destroyed by the complement, and it causes inflammation, and as a result a purely glomerular disorder will become a tubulointerstitial disorder, and the renal disease progresses slowly, and they come to us at a later stage when you cannot reverse it. That is a problem. So I'll tell the practitioners and the medical students here to stop calling this as a salt in urine or uppu sattu, and please make a point, it is a protein leak, a renal disorder, early finding of a major renal disease, and also elicit the history of travel edema. These three things for an urine albumin will do a good to the patient. Next thing, the very easy test is serum creatinine. And we know the serum creatinine values less than 1.4 or 1.2 or whatever it is a normal kidneys. And when we call it as a mild renal disease, moderate renal disease, severe renal disease, it depends upon the practitioner. Somebody call a creatinine of 4 as a mild renal disorder. Somebody calls a creatinine of 7 as serious disorder. Somebody even says when the creatinine is 7 or 8, you don't have a symptom, don't worry about this. The creatinine always goes up and come. You take a creatinine, you are fine. That's how the creatinine is being treated. But what is the fact? The creatinine is one marker which tells about the renal disorder, but this has to be interpreted in terms of a eGFR, estimated glomerular filtration rate. That is the actual parameter of the kidney function. When you say that normal GFR is around 120, and you till get the GFR decline up to 60 or 70, the creatinine remains the same within the normal limits. This is a very tactical issue. When you get a creatinine of 1.5 compared to the normal creatinine of 1.4, we tend to disregard this as a mild elevation of the serum creatinine. Just ignore it, you will be fine. Because it is synonymous to cholesterol and sugar. A cholesterol of 200, if you get a serum cholesterol of 201, you don't jump into the treatment of a hypercholesterolemia. A fasting sugar of 120, if you get a fasting sugar of 121, you don't jump into the treatment of diabetes. Synonymously, if a creatinine of 1.4 normal and if your lab gives a report of 1.5, we just ignore it. But what happens inside the body is different. When the GFR drops more than 50%, then only the creatinine rises by 0.1. So a creatinine of 1.5 indicates already the individual sitting in front of you has lost 50% of his renal functions without any symptoms. That is very important. When the creatinine is 2, the so-called mild kidney failure for a common practitioner indicates a major blow to the family. The GFR is around 20 or 30 ml. And when the GFR touches 10 ml, he needs dialysis. So he is left with only a GFR of 20 ml when we call it as a mild renal failure. That is a fallacy in diagnosing the renal disorder. That's how that bolt comes. This is not a blue. There is a lot of clouds in him. And the bolt is naturally happen, but we ignore the clouds and look at the bolt. So, how to diagnose a renal disorder when the GFR does not cause an elevation of creatinine, but still there is a renal insufficiency. That is a period of GFR from 120 to 60. There comes the usefulness of other parameters which I told you earlier, the hemoglobin. The hemoglobin, we know the renal has an excretory mechanism and production mechanism. The production mechanism is ignored. The production mechanisms are the hemoglobin is induced by the erythropoietin from the kidney. The vitamin D is activated by the kidney to absorb the calcium and keep the bone strong. And that buffering, pH buffering is by the kidney. BP control is by the kidney. So many things are produced by the kidney to keep us healthy. When the GFR drops, probably the excretory function may not show up, but the production mechanism drops down and it presents like anemia. And anemia in an individual of 30, 40 cannot be due to a worm infestation. And anemia in a female of 20 without a pregnancy cannot be a physiological. But we tend to miss that drop in hemoglobin and put them on iron, and we leave the renal disorder to progress. Like that calcium deficiency. The calcium deficiency will not come and sit in front of our eyes as a calcium of 7 or 6.5, but it will produce as a bony weakness which manifests as a evening tiredness. After the work, when he goes home, he is somewhat tired. But what we can do, we can give Horlicks and make him happy. That's what the advertisement says. But it is not so. The calcium may be low. The person develops a subtle renal metabolic bone disorder, becomes tired and weak, lethargic. Some people even develops a loss of potence in a female and male. The same menstrual abnormalities, hair loss, memory loss. So many deficiencies of the anemia which presents, we miss it. Then the bolt strikes us. And hypertension is a renal disorder abnormality, but at the same time, the so-called hypotension or postural hypotension can also suggest some sort of renal dysfunction. We will see how it is. So by looking into the serum creatinine alone as a parameter of the renal function, without looking into the eGFR, we lose time, which we should not do hereafter. I think that will help the individual to preserve the renal functions for quite a long time. Then the so-called renal scan. The third parameter we do in our clinical practice to diagnose renal disease. An ultrasonogram is mandatory, I would say. It is not an extravaganza. In an outpatient clinic of any physician or a nephrologist or anybody else, there should be an ultrasound machine in his table, which is like a laptop. You can do the ultrasound, see the kidney, because that will tell about the renal functional status. See, when we were MBBS, we used to diagnose mitral stenosis, mitral leakage with a lot of difficulties, but what is the use now with the echo? Echo is an outpatient procedure. Likewise, an ultrasonogram should be an outpatient procedure. It is an integral part of your clinical practice, and you should pick up the renal disorder very early. We do ultrasonogram nowadays, but we miss it, because when a mild increase in echogenicity is regarded as nothing but normal. When the kidney doesn't shrink much, it is considered to be normal. Only when you get a contracted kidney of 6 or 7, we give an importance. It's not like that. Even a just mild elevation of the echoes with the urinary abnormalities or a reduction in hemoglobin, calcium abnormalities or a hyper, all these things should make us to think that individual may have a renal disease, and we look into that one, pick up the chronic renal failure, put him on appropriate treatment, he gets a good life. The other side of the ultrasonogram is normal sized kidney. When you get a normal sized kidney, it does not tell the normal function. The structure may be normal, the function may not be normal, as in diabetes mellitus, some of the glomerular disorders, and in early stages of hypertension. So do the ultrasonogram, interpret with a caution. Interpret this with other test reports. So, as I telling repeatedly, look for other parameters actively in an individual and go for the diagnosis of renal failure in a combined way. History, urine routine, serum creatinine with the eGFR, and other functions of the kidney like hemoglobin, either a drop in hemoglobin, and hyperuricemia, drop in serum albumin, low calcium, high phosphorus. They should make you to think of a renal disorder. This uric acid needs some attention. Uric acid may be the effect of a renal disorder, or a high uric acid may cause a renal disorder. Pay attention to that one. Then the serum electrolytes, most often missed in the clinical practice. It is only done in ICU settings, post-op settings, or some inpatient settings. But the serum electrolytes should be an integral part of your outpatient investigations. And hyponatremia, a common disorder, it's probably due to iatrogenic, because we tell a edematous patient or tell a hypertensive patient to restrict the salt in the diet, and he restricts the salts unnecessarily, goes for hyponatremia. Whereas potassium disorders, hypo or hyper, both indicates underlying renal disorder, make it a point, unless otherwise proved. And hyperkalemia will indicate a distal renal tubular problems like obstructive uropathy, renal stones, pyelonephritis, papillary necrosis. Whereas an hypokalemia will tell of a renal disorder wherein the proximal tubules are a deficiency. So these parameters will make you to have a decent diagnosis, make the individual to get an early diagnosis, and we need not wait for the advanced stages of uremic syndrome. What we get as a referral nowadays, or what you see in your practice, or what we think as abnormal is an edema of the leg, facial puffiness, and oliguria, hematuria, anuria, or fatigue, pulmonary edema, all those things we think as symptoms of renal disease. They are not the symptoms of renal disease, but they are the symptoms of advanced uremia. At the stage, we have only one option, dialysis and transplant, whereas earlier we have more and more options to treat a renal disorder. And we know that CKD has stage 1 to 5. What is the relevance? All the stages have a cardiovascular risk. Maybe stage 1 have 10% risk, and stage 2 has a 20% risk, and stage 5 CRRT or dialysis, when they go for it, it has a 50% risk of cardiac death. And this is a small table which will make you to differentiate between the chronic glomerulonephritis and interstitial nephritis on table. If you look into the chronic interstitial side, there will be no symptoms of renal failure. There will be no oliguria. There will be no edema. There may not be an hypertension. There is a good output. In fact, there is polyuria or nocturia, and the person walks into a clinic without any symptoms. But they can harbor a chronic interstitial nephritis. Whereas CGN, it is opposite. Early stages, edema, facial puffiness, hypertension. Likewise, when you look into the diabetic nephropathy, you have to differentiate whether it's a diabetic kidney disease in a diabetic or non-diabetic kidney disease in a diabetic. Very important. It is based purely on the fundus and the history. Okay. With all these things of diagnosis of CKD, what we have achieved so far, the reality is somewhat different from the expectation. The individual sitting in front of you with a creatinine of 2 or 2.5 will expect you to reverse the renal functions back to normal. Not possible. Then he will tell you, at least make my creatinine stable at this point, I will lead a comfortable life. Not possible. Creatinine is going to deteriorate. And he may say, even if the creatinine rises, it's okay, but I don't want to enter into dialysis. Not possible. Then why a doctor, a physician, a nephrologist should treat a CKD? The answer is very simple. You need a long life. Whether the individual has a CKD or an advanced renal disorder of any type, you need him to lead a normal life. And the normal life is possible only when you treat the CKD in the early stages. Prevent his cardiac problem, prevent his neurological complications, bone marrow related problems, and treat his malnutrition and anemia, which is part and parcel of a CKD. If you don't treat the malnutrition and anemia, the survival will not be long. To treat the anemia at any cost, please don't go for a blood transfusion for an individual with CKD. I'll tell it 3 times in this session. I tell why at the end. So by treating the CKD, you give the family and the individual a quite comfortable, long, healthy lifestyle. And during this CKD progression, to say a creatinine of 1.5 to creatinine of 10 or 12 till he needs the dialysis, your responsibility is more in making him to avoid any medical complications like pulmonary edema, coma, seizures, or other advanced uremic symptoms. Further, to educate him well in advance. When a patient sits in front of me with a creatinine of 2 or 2.5, I talk to him till the renal transplant. So naturally, 50% of my patients will be lost for my practice. They will not come to me again for 1 or 2 years. Then they come after 2 years. 2 years முன்னாடி பார்த்தேன் உங்களை, I forget. அப்போவே நீங்கள் சொன்னீங்க டயாலிசிஸ் தேவைப்படும். எங்கள் ஃபேமிலியில் சொன்னாங்க, அந்த டாக்டர் வாய் வச்சு அப்படியே நடந்துடுவாங்க, போகாதேன்னு. I mean, no, it has happened, I will come back to you. It's not me who cursed him. Because we know the CKD progression is like that, we tell them. So they come back. But they come back with anemia, volume overload, bone marrow, bone mineral density related problems, cardiac risk, everything. So keeping him on dialysis will not give us very long survival. Whereas, if you follow him meticulously, get a AV fistula created when the creatinine crosses 6, keep him ready for a dialysis. At the earliest uremic symptom of nausea, vomiting, anorexia, if you take him on dialysis, no more the dialysis procedure needs hospitalization. It is an outpatient procedure. He comes there on a regular follow-up, creatinine 6, get AV fistula, educate him about the uremic symptom, put him on a proper diet. Once he touches the uremic symptom, says, I have a vomiting doctor, educate him, he needs a dialysis. Just dialyse him and send him home. Next 3 days daily dialysis, then twice a week dialysis. He happily goes to his work. Maybe he will need 10 days of medical leave from his job. We have kept many people who are surviving for more than 13, 15, 17 years on dialysis and making them earn their familyhood. There are painters who hang with a rope and do the painting, come for the dialysis. There are official people, there are doctors, nurses. They are all on dialysis. But only one thing